Hi everyone, welcome to the second annual Caring Discourse conference. Last year's conference was small but successful, and it's a great pleasure this year to host another forum for sharing research, although with a different format. It would have been a pleasure to have hosted you all here in Lisbon, but we still hope this online format allows to maintain and preserve the space for discussion that Caring Discourse represents. This year's topic is on conceptual, ethical, and practical challenges to the shared decision-making paradigm, a hot topic in health communication. Shared decision-making, as our keynote speakers have already addressed in their talk, is more of an umbrella term than a unifying concept. There are various aspects of what shared decision-making means or implies. To share decisions, sharing of decisions, to make informed decisions or contextualized decisions, deciding together, share understanding, and so on. All of our speakers with their talks have helped shed more light on these different aspects of the same question. Most of you have already watched our speakers' presentation on YouTube or Facebook, and so today you will have the opportunity to ask our speakers any questions or express any comments you might have. In fact, as with any conference, the symptom of a successful conference is when the participants build together a common ground, asking questions and discussing ideas. And I hope there will be a lot of that this morning. So, before we begin, let me give you some instruction. I just want to remind you how you can intervene with your questions and comments. You can always comment on the live chat, but if you want to address something to the speakers, please start your comment with a question for the speaker so we can relay it directly. If you would like to join us via video feed and ask your questions directly, please send an email to caringdiscourse@gmail.com. And you will receive an email back with the link to join the live feed. There is no need to install any software, and it's honestly very straightforward. Just click the link and wait for your turn. The moderator will let you in. So now I'd like to give the word to my colleague, Fabrizio Macagno. Hi, Fabrizio. Welcome.
Hi.
Discourse. Fabrizio Macagno is the principal investigator of the MetaCare project, evidence-based metaphors for diabetes care, which promotes this conference. I leave the word to you, Fabrizio.
Okay, thanks a lot, Maria Grazia. And I would like to, first of all, thank Maria Grazia, for all your effort, because transforming a physical conference into a virtual one is a tremendous effort, and it's also a tremendous work, because you spent a lot of time in making this possible. But it gives also to this little event that is limited in space and time also a very big event in truth, because it can be accessed by many people. So thanks a lot for this wonderful idea you had and all your time you devoted to it. I just wanted to spend very few words on the meta care, more concerning what it means than what it is, because Maria Grazia has already, and these talks already explained very well what it's about. Meta care is more than a project, a challenge, because takes as an object the use of metaphors in care and diabetes care in specific from an interdisciplinary perspective. Interdisciplinary means that some of us are from linguistics, some of us are from philosophy, and at the same time, we are share all an interdisciplinary background. For instance, Maria Grazia is from cognitive sciences, but she's working in communication and philosophy. I am from argumentation, which in itself mix between different disciplines. Also, Vito works between linguistics and visual sciences. So, MetaCare is truly interdisciplinary for many reasons. Besides, it wants to involve physicians, so people working in the field, psychologists. And this effort is not really common in an academia that where interdisciplinarity is just an empty word, because in truth, journals, disciplines, even the positions are defined very strictly by a specific disciplinary field. But we believe that only by combining not only different disciplines, but also different areas of expertise, such as the practice and the theory, you can really do something for society at large. And in our previous talks with Sarangi, he really pointed out that the risk is very high, because we are always in the periphery of academia, in the periphery of everything. But it is a risk that for us was worth taking. And the Portuguese FCT, which is the Science Foundation, in a sense, awarded us with this money and with this project and with this possibility, because they trusted that this is a unique chance. And in a discipline and in a country where health communication is not really that developed, this project can mean something, and also can mean something for the practical sciences, where in interaction with us can develop something and take something out from our purely academic discussions. So we are trying, and Maria Grazia is doing most of the work, trying to do this connection, this complex connection between practice and theory. And on the other hand, we are all together trying to make the connection between different disciplines. So showing how philosophy is not only something in the air, something that is related to discussing ideas, but something that has to solve problems. Communication is not only discussing the macro structure and the statistics, but to see how the process of decision-making works, and how specific problems in the field can be solved. So, and linguistics is not only looking at the syntax or semantics, but really at the interaction. So we are trying to interconnect fields that they indeed are somehow related, but relate them actually is really complex sometimes for many other reasons. So I would like to thank everybody for joining this discussion, our keynote speakers that devoted their time and their stress to be taken on a platform that is not their, let's say, usual stage. And I like to thank you everybody also for joining this discussion and attending these videos. I give you the floor.
Thank you a lot, Fabrizio, for your words. And of course, I hope to see you later during the discussion. So it's with great pleasure that I invite Paul Gulbrandsen from the University of Oslo and Srikant Sarangi from Aalborg University to join me. Hi, Paul, and hi, Srikant.
Hello.
Welcome. How are you?
I'm good. We are actually, I think it's hotter here in Oslo now than in Portugal, so we're happy with those few weeks or days.
Yeah, here we have a very nice temperature these days.
So what are we missing?
A beautiful city.
So why can't we share the weather?
Sorry?
Why can't we share the weather?
I cannot hear you very well.
Right. Can you hear me now?
Yes.
Why not share the weather rather than decision making?
Okay. Now get you. Could be an idea. So I'd like to welcome both and thanks again for being here and for participating in this conference. I'm honored to have you here with me today as keynote speakers of this conference. I see that there are some participants queued up to ask questions, and I will give the word to them shortly. Before, I'd like to start this discussion with provoking questions for both of you. So, starting from different perspectives and backgrounds, in your talk you discussed the concept itself of shared decision making in very interesting ways. So thank you for this. Both of you suggested that we should give up in some way the shared characterization of the shared decision-making paradigm. You, Paul, referred mainly to the importance of having contextualized decisions, giving more importance to patients' social context, and you, Srikant, argued for the importance of having informed decision-making to give more power to patients. So, and here it comes my question. What is left of the shared decision-making paradigm as we knew it?
As I said in my talk, I mean, I am in principle a proponent of the thoughts, at least, behind shared decision making. I think we need to realize that if we go 4 decades back, what we are now talking about as shared decision making was hardly seen at all in medical encounters. You could see it somewhere, but mostly. So to me, I think of it as a necessary ideology for changing medical practice, how we think about talking with patients. However, I'm concerned because I've seen so many videos now. I've been studying this for 20 years, where I see doctors really try sort of to do it, but they don't seem to succeed very much. And I've been thinking a lot about why it is so. And I don't have one single answer to that, but I think one of the main challenges is the enormous power differential between doctors and patients. And the benevolent characteristic of doing medicine. So you're doing medicine. You're in principle thinking that you are doing good. And that makes you blind to the power you're actually exerting. And this power, which is for the good, actually, I would say, silences patients. You don't really get what you would in a normal conversation between friends or many other kinds of conversations. You don't get a corrective feedback that tells you that now you're actually not treating me on equal terms or with the necessary respect. And the doctors don't understand it. So what's left, I think a lot of the important thoughts behind shared decision making is left. And then that's my second point. We are still in medicine, even if we have George Engels' biopsychosocial model, we are thinking about things that happen to patients as something that is either biological or psychological or sociological, while I'm concerned that we don't realize that a patient is an integral learning body that has been learning from the day they were conceived, or at least from the day they were born, and that every second of their life has formed their way of feeling, expressing, being able to understand. And in medicine, we're still too much bio. We're just thinking, working as people were objects, because it's very efficient many times, and forget the subjectivity.
What you have said about the lacking of correcting the feedback, it's very interesting, because so many times when I'm talking as an analyst now, you look at the transcription or at the video, and you have a lot of agreement, no, apparently between the patient and the provider, but many times you don't know exactly if this agreement is something that is an actual agreement, or perhaps you are just avoiding to give what you have called a corrective feedback. And I now leave the word to Srikant.
Okay, I think, can you hear me?
Yeah, very well now.
Okay, I think the question is more fresh than what I said 10 days ago. So I can't remember what I said. Now, of course, I agree about the ideological aspects of SDM. That is a goal. It's a kind of a sense of norm, objective that clinicians would like to accomplish. But I fully agree with Paul that, of course, that is never going to happen. But I'm also thinking about why STM has become so important right now or in the past few years. I don't think it is just an ideology or something to be desired. Mm-hmm. It's also a necessity, because there are many new situations, new syndromes, new unexplained illnesses where decisions cannot be made. So I'm reminded of David Silverman talking about scenarios where the clinicians are forced to demedicalize the clinical context because they can't have enough medical expertise to offer a decision or guidelines. So when we are talking about shared decision making, it's not a question of giving up. I think the point I'm trying to make, or I was making, we shouldn't take it for granted. And clinicians, what they understand by shared decision-making and how they try is not quite the same for analysts and communication researchers. So I think we need to rethink, can we analyze shared decision-making, or should we really be focusing on how decisions are communicated, not made? Because the making of decisions, which requires getting into the thick of the context, the patient's experiences, their life world, their expectations, are beyond many of us. They're also beyond the clinicians. So there are two things I want to go back to. One was, of course, the classic work of Elliot Mishler, the voice of medicine and the voice of the life world. So it's very important to recognize that the clinicians will be guided by biostatistics, biomedicine, the voice of medicine, the evidence that they have. And the patient's life world, the social context, is not quite the same, nor is it easily accessible either to clinicians or to analysts. So we run a risk of trying to medicalize the social context. And Howard Wedgkin, I think one of the other person I wanted to mention, the classic book, 1991, The Politics of Medical Encounters, where he says that patients don't bring physical problems to the clinic, they bring their wider social context to the clinic. But clinicians don't have the time, nor the inclination to unpack that whole social context at work, in the family, and patients may not quite openly disclose, because after all, it's a context of two strangers, even if one is an expert, sharing or talking in the clinic. So we are really about how much information can be shared before shared decision-making can happen. So what is remaining of the shared decision-making is the shared nature of information exchange. I think we need to focus on that. The shared understanding, how it is manifest, but exactly how decisions are made, where they are made, who triggers, who initiates, and who agrees, are sometimes far more complex, and they may not be visible at the level of the transcript or in the clinic encounter.
Thank you to both of you. Of course, feel free to interact between you also, but I just want to add, before giving the word to the other participants, that I hope that we will have the time to come back to this notion of the patient as an integral learning body, but also to the distinction you made, Srikant, on the decision on the communicated decision versus the decision we make within the encounters. So I see that we have some questions already, some people here listening to you. So I would start giving the word to Sara Bici. Hi, Sara. Welcome.
Hello, good morning. Thank you.
Morning.
Morning.
How is the weather?
It's pretty nice, thank you.
So, Sara,
Yes, so I would like to thank both speakers for very rich and interesting talks that I really appreciated a lot. From the point of view of the linguist, I appreciated them in particular because from my point of view as a linguist, I had the feeling that as researchers, we were kind of trapped into this phrase, shared decision making, and you feel it coming and going in research articles but sometimes, as you both pointed out, in a rather rigid way, so that you don't really know what people are talking about at the end of the discussion, let's say. And so I particularly appreciated the way you unpacked from different perspectives, but coming to similar considerations in the end, this concept of shared decision making. One point that interested me and that makes me think every time I come upon articles or editorials or talks that try to discuss this concept is the idea of person. I mean, in both your talks, more or less directly, you both hinted to the fact that you both referred to the fact that shared decision making has to do with the person-centered care, person-centered paradigm. And here is my comment and the question to you. Sometimes I have the feeling that part of the rigidity of the fixedness of this concept has to do with the fact that we talk about person at the center of care, and we sort of superimpose a way that decisions should be made, but then at the end of the day, I have a feeling we're never really sure what we're talking about when we refer to the persons that are actually involved. I have a feeling there's a lack of agreement, or maybe a lack of clarity would be better to say, regarding the definition of the person, because then if you have a clarity on that, then you know what to expect, sort of, in terms of interactional behavior or behavior in general. And sometimes I have the feeling that in some of the definitions of shared decision making, there is a presupposed idea of a perfectly rational agent or not perfectly rational agent. And I would like to know basically what you think about this, if you think there actually is this component, or it's totally out of the question.
Shall I start? First of all, just briefly, Sarah, I think it's important to distinguish between person and patient. At least to me, when you see a person in your office as a doctor, and I've seen many, it was important to me to see the person and not the patient in that specific situation. And to me, every person is interwoven into the world. It's not an entity that is limited to the skin. It's completely interwoven into the world. And as a small contradiction to what you said, Srikant, most of my colleagues would say they don't have time because they are very busy and they have a lot of difficult things to do. And of course, sometimes they're right. But when I changed my practice, when I started to think and then started to read and then started to learn and then change my behavior in the doctor's chair, I saw I did have time. I just saw the world and the person differently. And it made a big change. I understood much more of what the person brought to me as a patient. So I never accept that. There are situations. Medicine is very, very diverse. There are, of course, situations where doctors don't have time and they save lives and they have to come do that. But we're talking about change making. We're basically talking about meetings where the person, the doctor, the person, the patient meet and have some time to talk.
I think, can I come in?
Yep.
I just want to clarify what I meant by the tyranny of time. Not so much. I fully agree. Those who want to give time would like to learn more about the patient as a person and take into account the context of the decision making and the treatments and so on. I'm very well reminded of Glyn Olwyn when he was my colleague in Cardiff, developing his STM models.
Yeah, of course you are. Yeah.
And he was at the same time practicing as a GP. So I knew his colleagues in the clinic, and they were all very dissatisfied with Glyn taking more time with the patients to reach shared decision making with the choice talk and options talk, when his colleagues had to mop up the floor and see more patients because each clinic appointment was 6 minutes in the UK. So time is a more serious issue in that sense, in a more kind of an institutional sense. I think the shared decision-making not only needs more time, it also needs more time when the patient is from a different linguistic, ethnic background.
Absolutely.
When the patient has an interpreter in the clinic, but the regulations don't allow for more time because you have an interpreter. You are a refugee, you are an elderly person who don't understand the conditions. So I think that's the kind of thing we're talking about as the time as a very important, which also means the context of the clinic. But let me come back to Sarah's question, and I think there are two parts to it. One is about, and I agree about not conflating the patient with the person that Paul mentioned. The patient has come to the clinic not just as the person outside, but as a particular kind of person with a particular concern, worry, anxiety, expectation. So when we talk about person-centered or patient-centered, to me, it simply means being sensitive to the context of the patient. And that context, as we have been already talking about, is pretty nuanced and very complex. And even the clinician doesn't have full access to that context. So the context is not just there, it's another of those words that is as problematic as shared or as person-centered or patient-centered. What do we mean by context? How much of the context is going to be shared? Who is going to share, and why should they not share? Because they might have some concerns. So that's one of the issues about patient-centered, person-centered, shared decision, patient autonomy. All these concepts are problematic at the analytical, communicative level. And that takes me to the first point you raised about my response is simply, of course, we should be looking at shared decision-making, patient-centeredness, person-centeredness, and how they are differently manifest in different clinical contexts or disease contexts. But that should not be our starting point. We shouldn't start as linguists and communication researchers with shared decision-making. As a bandwagon, it's there, and now we see how it is done. Instead, we should actually be more comfortable allowing for our expertise to see what's going on. And that's what I meant by how they communicate decisions or information or understandings. That we can. I feel more comfortable talking about shared understanding and shared information than shared decision because I don't see it. And it is never there from start to finish in a clinical encounter. So do we join a bandwagon, whether it is patient-centeredness, patient autonomy, patient empowerment, shared decision? Those issues are crucial to how healthcare is managed and delivered. But we are at one remove from those issues without expertise. So with language, communication, interaction, we might say how these things are manifest, displayed, pan out at the level of the clinic. So we are not sure whether it's a shared decision making after we have done the analysis, even though that's what they think it happened. And there are many, I think I'll just give one example very similar to shared decision making in genetics about non-directiveness or neutrality. So I had a group of genetic counselors, my own colleagues in Cardiff. I gave them a transcript and I said, please find out where non-directiveness is happening. And they couldn't agree. So in other words, even those who believe they're doing non-directive counseling, shared decision-making, informed decision-making, it's pretty hard to put your finger on a particular clinical encounter or a transcript, say, that's where it is. And we all agree.
A brief comment to that, actually. I agree with you, Srikant. So, but these are two worlds, the medical world and the linguistic and the philosophical world. Yes. They're very different. And doctors are trained to do things. So when
we are trained to undo things.
You are well, yes, but you're also trained to think. So we're trained to act, and also in cases of much uncertainty. So even if we have symptoms or diseases or things that we don't really know how to handle, we still do something. We make recipes, we make algorithms, whatever. And when doctors sort of discovered the problem of our communication, they started to make recipes for the communication. And that's really hard because every communication is unique. And that's why in my teaching, I'm not so much focused on, I'm focused on some ground rules of communication, but I'm not so much focused on all the complexities of STM, but rather on a different way of thinking about talks. Let me stop there.
I think I am a little worried about doing versus thinking.
Yeah.
I hope doctors also think, not just do.
Oh, well, no, but this is serious.
No, I know. But what I meant, I'm picking up on the more and more there are uncertainties and unexplained symptoms and whatnot, and the more ethical issues that come up with many situations in the clinic. Doctors are supposed not to do because they can't do, and that doing might be problematic and unethical.
But I completely agree with you. But this is actually this is a really important problem in medicine.
Yeah.
Because we are trained to act, and we are trained to do something also when there is uncertainty, and uncertainty is, however, not one thing. It's a very, very large or a very small thing. It's a very dangerous thing or not very dangerous. Yeah. So there are tons of different things there. But so many young doctors are thrown into our discipline with their heads full of facts, and they come in there and wow, the world with patients look differently. Some patients fit perfectly into the library and they don't know exactly what to do, but I would say the majority of patients do not fit perfectly into the library. And then if they're not having a very good supervision in their young years, and many do not, they actually start acting just because they need to act. And this is, so I don't think this, maybe we should walk down this road the rest of this discussion, but I really want you to know that the world seen from the medical office and the experiences of the doctor are actually very, very forming for how the talks with patients and persons are actually developed.
Let me just add and then move on. I think that what we are talking about is not two worlds, but three worlds. The world of medical education, what they are taught, which is probably where the problem lies, rather than what happens in the clinic and the world of the clinician. And then the world of the communication research or the researchers. So we have to somehow try to connect these three worlds in what we're talking about. So there are problems about, of course, you have to teach them in a very watered down way of what is shared decision making, what is patient autonomy, what is good and bad communication. You can't deal with the nuances and the complexities. In the clinic, you have to act. You can't just say, let me go back and I'll read something and come back and think. In the communication world, we are divorced from those two, how they are taught and what actually happens. All we have is just access to what is captured in the transcript or in the video or whatever, and something escapes. So maybe there are more than two words that we need to think about and connect the dots. Right, there might be more questions and more.
Yeah, thank you for this very dense
Thank you.
Answers. Thank you, Sara. I'll see you later. I give now the words to Fabrizio that has a question also.
I got a question. Hello, I got a question for you.
I actually have a question for you first. Where is the dinner tonight?
I think it is related to my question because it's going to be asynchronous. So,
and can you ever go back from virtual to physical? That's what I want.
It is a little bit difficult, but still we can have dinner together virtually.
Okay. Right. Anyway, go ahead.
No, it is related to, I loved, first of all, your talk. And I got two little issues that I would love you to expand on. One is I was very much interested in the fact that you pointed out that many decisions are really made, but not at the same time and at the same place, that patients make the decision together with the family many times and after the visit, and then the doctors made the decisions together with the colleagues in concerning matters of health economy. And so this is not a synchronous decision, but occurs in different times and places, and makes a huge sense to me because the time made me reflect on the times that I had to make a decision concerning my own health. And once it was synchronous, but it was not an option. There were no options. And the other time I made a decision, but after weeks. So it makes a lot of sense what you said. And another point is the concerns about the ethics. I totally agree. And also looking back at my experience, when I had an issue, I had to change hospitals to see whether they were honest in their opinion that were giving and their recommendations. And I stopped when, first of all, I saw real evidence coming out of what they were saying. And second, they simply asked me, what do you want to do with your sports life? Because they first, with my sports life, I mean, do you want to move on with professional career, or you just want to be an amateur? Because in one case, we recommend surgery. The second case, what's that for? So, but my question is, in this, when ethics becomes so predominant in the decision making and in communication, what is the field? How can we investigate ethics? Because it becomes much more complex. It is easy to analyze communication up to a certain extent, But when ethical matters pop in, and I totally agree, they are crucial, I don't see methodology to do that. I see an empty field in front of me, and it is very much more complex to see, to analyze, to coordinate with doctors. I think in a certain extent, communication can be an instrument, is in a sense less invasive, saying, look, this is a better communication technique, but it's much harder to transform it in an ethical instrument.
Shall I have a go first? Okay, I think let's go back to the issue of where the decision is made. And there are two aspects. One is the temporality, the time dimension, but also the sequentiality in terms of what happens in the clinic. I think it's sometimes it's easy to identify where a decision has already been made beforehand and then is communicated. I think there are ways of locating that in the interaction. It's very similar to, I always feel about my active academic life, whatever that was, to go to a staff meeting when you have to make decisions about students, about staffing, about conference spending. I never had any doubt when decisions were already made by the head of the department. And it was only being communicated. And the minutes of the meeting will show that it was agreed or shared or whatever. So decisions are made in the corridors, in the clinics, in the car park, in the kitchen, in the patient's house. And then they are somehow captured or clothed in the clinic and presented as shared decision. In that sense, it's not a bad thing to say that, of course, we have thought about this. We want a second opinion. We want it to be shared. We want to consider the pros and cons, the consequences of going this way or that way. So that doesn't prevent the unfolding of the decision and the consequences, but that's not the shared decision at the same time. Okay, so that's very important, I think. And I keep saying, maybe one of the things I am much more clearer now is, should we be focusing on how decisions are communicated, if at all, as opposed to how decisions are made? Because how always implies where and who, and we may not have access to those. The second point is about ethics and communication. And I think both the disciplines have principles of communication, rules, norms of communication. Same with ethics. There are principles of ethics. So both disciplines are principles driven or principles bound, but equally they're context bound. No ethical principle works in every context. No principle of communication works in every encounter, in every clinic. So what might be a lifestyle decision for a sports person with a particular condition is not the same for an academic. So I guess we then are talking about, the more we become sensitive to the context, both as communication scholars and ethics scholars, the less we can generalize and abstract, the less we can say there is a strict, clear line between ethical and unethical conduct. But that doesn't stop us from addressing ethical issues in context-sensitive, culturally sensitive ways. Then on the top of that, you add the clinical context as well, which also is equally variable, as Paul has been saying. We're talking about a whole spectrum of medicine, healthcare. And I think I feel more and more uncomfortable as I speak. Can we talk about shared decision making in healthcare generally? We can't. So we have to be far more specific in our research efforts, research work, to be as specific as we can. Which context, what kind of persons, what kind of patients. Then we might know more about what does constitute shared decision making in that clinical context with what we know. But the problem lies in a discussion of this kind. We try to overgeneralize, overinterpret, and we're never going to progress with our understanding because it's too broad and too vague, too abstract.
I would like to follow up. First of all, Srikant, I fully agree with Srikant in everything he says about this, and I think particularly one of the things.
Or do you also going to agree with everything else I'll say next?
No, I will not. But this, I follow you completely. One of the things that I really took from your talk, which is an important distinction, and that needs to be, put up and thought about always when we talk about shared decision making, distinction between decisions made and decisions communicated. And when you go back to when they are made, at least one of my PhD students, Eirik Ofstad, OFSTAD, made a very important study where he looked at 372 videos, and we saw how they are communicated. And we actually had to make two dimensions of a way of classifying decisions that appeared in encounters. The classification system is called dictum, but the one dimension was the temporal.
Mm-hmm.
How they were actually just brought in and communicated, how the majority, but not a large majority, of the decisions were actually appearing and coming up and was made there and then all the conditional decisions they were talking about, what if, then. And that's one of the complexities. And complexity is an issue here in what you said, but also in the questions about ethics. Because I'm not an ethicist, I'm just a doctor. I know the medical principles, the ethical medical principles. But there was sort of an underlying question here. When are we sure that the decision making or with decision communication is ethical? And I was thinking about that, and I could say there are at least a couple of questions here, and one of them is very, very difficult to answer, and the other is just a little difficult to answer. The first question is the patient or the relative or who else is in this conversation fully informed? What does fully informed mean? That's one of the things that make this proliferation of decision aids, because when doctors really try to put all their knowledge and the medicine's knowledge into aids like that, you realize how difficult it is to come to a point where you can say that this patient is actually fully informed. So that's a question of itself. Is that a requirement for saying that the decision is ethical, or is there a limit far before that? I have met 4,000 patients a year for 14 years in practice. They are really at immensely different levels of understanding, and many of them, and that's one of the things that is in this meeting between doctors and patients. Many patients want the doctor to do things and make decisions because they don't feel that they have the capacity. So how much are the doctor going to spend in order to make the patient be fully informed? And then second, and that's the other question that is linked to it, but it's a different question. Has the doctor, or have I as a doctor, promoted the patient's autonomy? Now, I'm not now talking about respecting the patient's autonomy, which is an important ethical principle, but I am asking, is a way of thinking about working as a doctor, asking the questions, have I now promoted the patient's autonomous capacity, given this situation with this person? And that's one of the things that at least helped me when I was working, that is the patient leaving this office feeling more informed, feeling helped, feeling that they have learned something, but not fully informed, but feeling that now I can manage my situation a little better than I did when I came. Not being overwhelmed by complexity, but being respected for the need as a person to be able to master, cope their situation a little better than when they arrived. So that's how I'm not able to put it in more precise philosophical terms, but that's how I think about how we can sort of evaluate what's happening, both the decision making in itself, but also how ethical it is.
So thank you for your replies. Thank you, Fabrizio, for your question. Bye for now. And there are other people here, and the time is running. So I'll give the word now to Margarita Figueiredo Braga. Hi, Margarita. You are muted. Just give him.
And now, are you
okay?
Listening to me?
Yeah.
Okay.
Welcome.
Okay. Thank you. Thank you for this interesting and provocative discussion. Thank you very much. I agree with most of your reflections. Of course, you have different points of view. If you are a clinician and you have a lot of points in your agenda, and as Paul was saying, you need to foster patient empowerment, but also you need to have decisions at the end of the consultation for the best of patient health and clinical outcomes. So I would like to comment and add something. As a psychiatrist, I had a lot of patients with depression, and what we have found in both in clinical work and in research is that patients are not always in the same position regarding their needs and regarding their ability to share decisions. When they are really with a severe depression, they don't feel able to share their thoughts. They even are not sure of themselves. They are insecure and anxious. So they want to be informed. They want that the doctor respect their points of view, but really they don't feel able to share decisions, and sometimes even not to pronunciate about what they want. But as they get better, they want to be more involved. So I would like to add, for instance, some disorders are particularly complex in how can I say it? In evaluating what are the patient's wills and needs in a certain point. So I would like to emphasize that we have to take care and at the same time teach our youngest colleagues and doctors to be sensitive, to follow the nonverbal cues of the patient, to assess how cognitively and emotionally patients are, and taking always the point of view of a very respectful approach and emotionally focused approach. They have to be able to monitor and measure how is the ability of the patient to get involved in a very difficult discussion about different treatments options and that kind of issues.
Do you want to comment on that?
I think just very briefly, it goes back to what I was saying about how we have to look at different contexts. So depression is not the same as primary care. Psychiatry is not the same as genetic counseling. So we have to be very, very context sensitive in talking about what can be taken for granted and what has to be worked up as the main goal of the consultation. And it also takes us back to issues of understanding rather than decision making. So how do we know that the patients understand the language of our clinic, the cues that we give? Even the nonverbal cues do not work exactly the same way across different clinical settings or patients. So when we are talking about cues, when we are talking about any strategies that we use to somehow optimize understanding, and that comes back to Pearl's point about how do we know when the patient is fully informed, has fully understood. There is no such state of full understanding, fully informed. So the notion of informed consent in itself is problematic. How do we know that the patients have been properly understood before they give informed consent? So we have very serious issues about these notions of understanding, informed, ethics, and so on. But what we can show, even in the context of depression and psychiatric cases, whether there is an improvement in the understanding over time from the way in which the interaction progresses. So what that means for me, what I meant by communicating decisions or communicating information also implies uptake of information, uptake of decisions, not just how the doctor communicates. There are two parties, both are communicating. So there must be ways in which we can locate, identify in a clinic encounter whether a person with depression over a period of 3 months, 6 months coming to the clinic has improved their understanding in the way they ask questions, in the way they engage in the topics. So that would be a way forward to think about whether there is progression in understanding rather than being a state of full understanding or fully informed.
Thank you.
I thank you for bringing in this perspective, Margarida. It addresses something that I have tried to write about that has a tendency to be sort of ignored, at least in the hardcore shared decision-making community, who are so much focused on the exchange of information and understanding. And that is that there is no such thing as a meeting in medicine that is completely without an emotional component. There is always some, and you bring in the severe depression, which is of course very important. But my perspective here again is that some sort of emotional affection is always there. And for most people coming to a doctor's office, even if it's not in psychiatry, I mean, wherever, the doctor would sort of know, because he's treating diseases, that there is anxiety. And that's probably, if any emotion is actually recognized, it's usually anxiety. Or it's not even just recognized, it's often anticipated.
Yeah.
So the doctors actually take for granted that the patients are anxious, even if they're not. But there are other emotions that are probably much more important for how the consultation is actually developing. And one of them that is by its nature hidden, and which is extremely important, I can remember from my practice, is shame. And recognizing shame, recognizing people, and I'm talking about shame in a subtle way, just the feeling of being inferior, the fear of asking stupid questions, and back down to the feeling of not being up to the standards of expectations. When doctors typically present their pre-assumptions about the patient, which are obviously often wrong. So that's why I want to promote curiosity as a very important leading principle of doing medicine. And if you're really curious, you're listening to the subtle signals that you're talking about, the body language, how they respond to you or not respond to you. And that is actually cues to at where am I starting this dialogue so to increase the patient's understanding and promote autonomy. But when patients are normal, not depressed, really depressed, we tend to ignore it. We don't think about it. We just do our medicine. Yeah. So, yeah, let me stop there.
Okay.
So, thank you, Margarita.
Okay.
We
could go on and on.
We will be depressed.
No. So I see that there are other people here, Julia, Monica, Tindusdo, and thanks. And also I have 2 questions for you, Paul and Sarangi, from a colleague of mine, for Florian, by question sent by Florian Figueiredo. And I want to thank you all for, but unfortunately we don't have time. I just would like to give the word to Vito for the last question of this session, but please try to stay in 5, maximum 10 minutes. You are muted, Vito. Okay.
Yeah. Now you can
Yeah.
hear me? Okay. So we were talking about context. Can you talk about some of the issues involved in patient expectations in the decision-making process? Even just
sorry, Vito.
You are breaking up.
Yeah, you have some problem with the connection or with the microphone. So try again, please.
Okay. So yeah, Paul said before that, for example, patients and their families might expect the doctor to make all the decisions and just tell them what to do. So one thing about context, more specifically, that I wanted to ask you was about culture. So what role does culture have in the shared decision-making process? So can you both talk a bit more about the role and perhaps the challenges of culture and different cultures in shared decision-making, not just from an ethical perspective, but from a practical one as well?
I could answer briefly, and Srikant will certainly have something to say about this.
I'll agree with you.
Yes. Culture is obviously and a very important part of this discussion. I tend to simplify it for myself when I think as a clinician, saying that, and partly because I've experienced it, So that there are large varieties in cultural thinking about how to do talks in a doctor's office. But I start when I teach my students to say that every family has its own culture. And so you actually have to find out before you start doing the process in the way you have been taught or think is right. You actually have to find out how is this person, this family, thinking about the process. And that saves time. I've experienced it myself. I've had several times I wasted a lot of time because I didn't. So, but obviously, because I think of the person or the human as a learning body, learning from birth to death, that depending on where they are actually developing as persons, there are a million different ways of thinking about this, and I have to find out. And the trap is to make an assumption about the person from Pakistan because you know something about how the Pakistan culture is thinking about this. Yeah.
Okay, I think I'll only add, and we have to be brief. Of course, culture matters because even the very concept of shared decision making is culturally grounded. So that already implies it is a good thing in one culture, but we assume it will travel across cultures in the whole world, and it won't. So we're talking about culture in the sense of the more biographical, which implies the family, the patient, and so on, and how much of that culture can be shared even before we get to decisions. The second aspect of the culture is the more ideological, what Muslim women are expected to do at home as opposed to Christian women or Hindu women or something else. So there is an ideological component, very normative, even if those norms are changing and shifting. But there are the biographical. The biographical ones, particularly me working in genetic counseling, are beyond any clinician. What information can be shared with whom in the family is very biographically sensitive, experientially. They will tell one sister, but not another sister about the genetic disorder. So these are ethical issues at the client's level, family level, but also at the professional level. And in order to avoid that ethical trap, genetic counseling adopted what seems to think is non-directive, which is equally problematic, also both as a concept, but also in practice. So culture is one layer of the context that we have been talking about, but that simply is not a simple layer. It's ideological, it's biographical, and of course it is family and person specific.
So thank you, Vito. See you later. And I think that we should close this session now. So again, it has been a great pleasure and honor to have you here, Srikant and Paul. I want to thank very sincerely both of you. And concerning the Caring Discourse conference, we come back at 10:30 to continue our discussion with the other speakers. So stay with us. In the meantime, just enjoy your coffee at home or your tea, or just do a little break. And I see you in 25 minutes. Bye.
Thank you.
Thank
Bye-bye.
you, Maria Grazia.
Bye.
Thank you very much.